Healthcare costs are climbing, and according to a new PwC report, there's no relief in sight for 2027. PwC just released its Behind the Numbers 2027 report, an annual survey of actuaries at 27 U.S. health plans covering more than 103 million employer-sponsored members and 8 million individual Affordable Care Act marketplace members. Group medical costs are projected to rise 9% in 2027, and within that, the rate of increase in pharmaceutical spending is the fastest it's been in years. Here to break it all down is Philip Sclafani, Principal and Pharmaceutical and Life Sciences Lead at PwC, and one of the key advisors behind this report. Philip works at the intersection of drug costs, payer strategy, and health plan economics, and there's no one better positioned to tell us what these numbers actually mean for the pharmaceutical industry. Here's what he had to say. So Phil, your report finds that more than 85% of surveyed health plan actuaries expect drug spending increases to outpace overall medical spending growth in 2027. When you look at what's driving that, is there one category that your respondents flagged as the most urgent cost management challenge right now, and why is that?
Yeah, I think maybe good to start from the point of kind of level setting on the increases that we're seeing. So total overall, looking at a forecasted 9% growth in total medical expense across medical and pharmacy. And it's another year of high rates. We've been in the eights, 8.5s, nines for the past couple of years. So we are in this period of sustained growth. What's a little bit different this year, what we've seen in previous years is medical cost was the majority of the cost increase and the fastest rate of increase. Pharmaceutical costs have been increasing as well as a minority of it. What is true this year, just to be clear, is medical costs are still more of the increase than pharmacy costs, right? The increase in revenue cycle management and use in AI and billing and hospital billing rates and behavioral health costs in general are still most of the 9%. The rate of increase in pharmaceutical spending is the fastest and faster than we've seen in recent years. To your question, that is really driven by a couple things. The headline is, of course, GLP-1s. It is for all of us. When we were looking at GLP-1 spending a couple years ago, it was $1.50 per member per month, and it grew to $3.50 and $5, and we were saying, holy moly, it's a huge piece of it now. This year we're seeing $30 to $50 per member per month, and expecting still more, 20% year over year growth. So the GLP-1 growth rate has been faster than we would have predicted a couple years ago, and still the expectation this market may double, triple, quadruple again, right? It's maybe 5% of the US population as of a couple months ago treating on GLP-1s, and if that grew to 15, 20, 30%, we could still see significant cost increases in there. So that's the headline and driving a lot of the rate of growth. The pace has been very fast. Underlying that, though, if you pull GLP-1s out of the market, there's still continued growth in oncology expense. It is one of those areas, again, where we're seeing great innovation, right? I mean, ASCO was just a couple of weeks ago, and some of the advances in pancreatic cancer and other times are extremely innovative, right? Doubling progression-free survival and overall survival. But that will come at a cost, and we see continued use of PD-L1s and BTKs and others that are significant expense drivers for the value that they bring. Alongside that, we continue to see greater use in a few other therapeutic areas, CNS, behavioral health, and other neurosciences. Again, really good innovations, but with those new treatments and innovation comes cost. And then the last piece we highlight is cell and gene therapy, which is still a small part. It's kind of like back when specialty drugs even were a small fraction of prescribing. I mean, they still are, right? Specialty drugs are between 2 and 3% of prescriptions, but over half the cost. Cell and gene therapy is a fraction of that, but expensive, right? They're million-dollar, multi-million-dollar curative treatments almost. If you have a couple of them, it's not a big impact. When you start to string together dozens of cell and gene therapies even for small populations, it matters and growing the overall trend. And I would highlight even where it's not necessarily driving the overall trend, it can be very impactful to a small, mid-sized employer. Like if you're the employer that catches that $5 million cell and gene therapy patient across your, like, it might be a one case per million lives, but you have 10,000 employees, you bear that cost. It turns your year upside down. So the cell and gene therapies are growing across nationally, but on an employer basis can also be super impactful when you catch those patients.
On GLP-1 specifically, the report notes that prescriptions filled in December 2025 were double what they were in December 2024. Many plans tightened coverage for obesity, but those restrictions seem harder to hold as approved uses broaden. How should payers be thinking about GLP-1 coverage governance now, given that the report itself acknowledges that the downstream reduction in overall healthcare spending that was promised with these drugs hasn't yet materialized?
Yeah, I think about the GLP-1s in kind of three buckets to go through. First is the coverage for diabetes, which GLP-1s are not new for diabetes, they've been on the market 20, 25 years. They're not unrestricted access to those, but there's some utilization management and prior authorizations required and all that. But those are fairly broadly covered and should be, as they are for diabetes. The obesity weight loss side is what has been growing in many years, and it's very much been for one, not covered by Medicare, right? And there's still the balance program and some things coming in that will or may drive Medicare coverage, I guess, depending on how that shakes out. But on the commercial and private insurance side, it's very much been an employer by employer decision. So like even where GLP-1s might be covered on a national formulary for one of the big PBMs, the employer still has to decide, am I going to, cover and pay for them for weight loss? And then importantly to your question, how am I going to cover it? Like, is it available to everybody? Is it certain BMI restrictions? Do they have to be part of a obesity management and weight loss plan and do these other comprehensive, sort of behavioral modification parts of it? And then it can be a question of, well, which GLP-1s, right? If you go with every manufacturer and all of that piece. That's the part that we've seen a little bit of a topsy-turvy, right? Some employers are adding coverage, some are taking away coverage, some are saying we can partner with these direct-to-patient programs and get access through there rather than covering it through our PBM. There's upwards of 20 various types of direct-to-employer programs and direct-to-patient programs out there that employers have options to work with now. So we've seen a lot of that going back and forth. Obviously, the market and sales have continued to go through that. So you see, maybe this gradual increase in coverage on that side has happened. At the same time, we've also seen this market not necessarily need that, right? I mean, I think 90+% of sales of some of the newer GLP-1s have been direct, or the orals that launched are not covered by any or and I shouldn't say any, like not widely covered at all, but have had incredibly fast launches, right? Tens of thousands of prescriptions per week. I think one of them just hit 3 million total prescriptions since launch in just a few months. So all of that has been the cash business alongside. And that's a very employer by employer decision, right? If you have employees that are going to be with you for the next 20 years, maybe you'll see some of the longer term benefits. If your entire patient population turns over every 3 to 5 years, maybe it's a tougher case to say I should broadly cover these, but employers are deciding that on their own and with their advisors. Across all of that, to the last part of your question, Stephen, I think important is to say what makes this so difficult is I look at incurring a large expense right now, right? I'm going to pay for all the people that use a GLP-1 now, and as a self-insured employer, I pay for that dollar for dollar. And yeah, I may not see the benefits of these for 5, 10, 15 years. Like there's been no long-term great studies to say these newer GLP-1s are going to reduce, MIs and cardiovascular events and improve pulmonary and cardiometabolic health and all of those kind of things. And that's really what you want as an employer, right? Like my employees having a lower number on the scale is great, but ultimately them being healthier, better health and wellness, and costing less long term is what we want to shoot for. And like that's sort of the conflict in this. Like you could argue all 300 million Americans should have access to a GLP-1, and that would be the best thing for public health. But as an employer with 5, 10, 15,000 lives, it's a real cost to say I may never see the benefit for all these people.
So recent approvals of oral GLP-1 formulations feel like a potential inflection point for prescription volume. The report suggests oral formulations could drive uptake beyond patient populations already managed under prior auth frameworks, essentially opening the door to a much larger pool of eligible members. Does that approval fundamentally change the drug cost exposure for payers and self-funded employers? And what coverage guardrails should they be building right now before the 2027 benefits cycle locks in?
Breaking that down a little bit, I think, no question, the approval of both of the orals on market is a seminal event for this market. Like, there's just, in every therapeutic area and drug class, having options from infusion through self-injectable to oral, the more of those you can cover, the more of the patient population you're going to bring in, right? There's just going to be some people that are needle shy that may have wanted the benefit of a GLP-1, but not to inject. So, and there's a barrier. Some drugs need to be refrigerated and they're just harder to get, things like that. You generally can't sample, or it's harder to sample. So, everybody needs to pay. But now the orals open up a new patient population, and are probably a little bit easier to sell through some other, direct to patient channels, things like that. It's also not the only innovation that will get there, right? The GLP-1, even science, has moved from kind of single agonists to now dual targets, and some triples will come. So the idea of like GLP-1s that help you lose weight, but also retain or build muscle mass, or have benefits in sleep apnea and MASH and other conditions and things like that, are being studied and coming. And there's another 5 or 6 pharma manufacturers with more innovation on the side coming, which will continue to grow this market. But for where we're at now, yes, the orals have opened up a new patient population for sure. They're at the place of too new and also focused on weight loss versus the diabetes side, that they've not really been picked up for coverage. I think it's a TBD to say, will those be covered or not? Or might an employer say, well, the self-injectable GLP-1s are going to be what I cover for diabetes, and I'm not going to cover for weight loss. And maybe that is where I go to some of the other like employer add-on or direct-to-patient programs and say, my employees can pay whatever it is, $299 a month for their GLP-1 oral. Maybe I'll facilitate that. I think that's where this market is going next, is employers maybe saying, some will cover it through their insurance. Absolutely. If that's their choice, great. For those that don't, they'll look at maybe an add-on or sort of subsidized program to offer benefits and access to orals, but not through their PBM. And I think the market's kind of going through that now, right? They're just too new. And like, you usually decide these every year, or maybe some will make mid-year changes, but most employers are on a calendar year benefit schedule. So you'll see open enrollment periods opening up towards the end of the summer, and they'll release their benefits as part of that. And we'll see like September, October in the fall, and then those lives will go live on new benefits January 1st of 27. So I'm sure manufacturers are working on it now for where it will be covered by the big PBMs and employers. Where there's not coverage, there's already great direct-to-patient programs that are expanding their capabilities even more for these orals.
So moving beyond GLP-1s, the report points to oncology as the structural backbone of rising drug spending. $143 billion in U.S. cancer medicine spending in 2025, with nearly a 60% increase projected by 2030. What levers do plans actually have to control per member spending in that space?
Yeah, and I think kind of where you're going, less than in many other areas. And oncology is its own space and treatments. And, for various important reasons, physicians and providers and these centers of excellence need the right latitude to choose the right drug and treatment algorithm, right? It's not even drug by drug. It's mixtures of drugs and lines of therapy. And a patient that has had surgery first and then moved on to a drug, or as refractory and later lines need different drugs and combinations of drugs. So it's traditionally been a much lesser managed space to get in there. They do things like, utilize the biosimilars that have launched to get savings while still giving the same or very similar molecules to patients and things like that. But unquestionably, as the new treatments have launched, as you mentioned, ADCs, bispecifics, et cetera, traditionally what happens is those drugs will be evaluated based on NCCN guidelines, and then payers will go ahead and add those to their, oncology medical policies, or there's some pathway vendors and others that kind of play in the middle And most payers will generally cover, somewhere to the labeled indications of the drug and or NCCN guidelines. And that's primarily, how things kind of from a policy perspective get put through. And then every payer has different levels of maturity for how they manage, prior authorizations and required step therapies, and will grant medical exceptions and things like that where they're needed. Um, that's more or less where oncology has been and sort of is. I think, maybe to your point, there's a little bit better control of the pharmacy benefit. It's more, there's more real time, right? It's built right into the point of sale. There's more rigor built around it. Just even like pharmacy has benefited from the spaces that can be highly managed, right? Like there's years of managing diabetes products where they can drive close to 100% share to one manufacturer if that's their preferred product, versus others where it's a little bit difficult to manage. Medical benefit doesn't necessarily have those requirements, but I would say like even if it did, even if I could manage, even if I said I'm managing everything through my pharmacy benefit, oncology would be a lesser managed space by the nature of it, both scientifically or clinically, and also it's just not a great thing to be. I'm the payer that denied the life-saving cancer treatment that's actually FDA approved and on NCCN guidelines. Most are not in that camp. So that's kind of where the market is. And to your point, yes, medical is lesser managed generally than pharmacy, but I'd really focus in on oncology. Like that's sort of what America does. We pay for access to those latest oncology treatments as they're approved and studied and approved and, evaluated by NCCN and other bodies.
Now, Phil, my last question. Your report raises an interesting tension around uncertainty with PBM reform, acknowledging that transparency and pricing changes may improve visibility into what plans are actually paying for drugs, but almost stopping short of saying those reforms will reduce what plans and employers ultimately spend. What's your honest assessment? Would PBM reform, as it's currently taking shape, actually lower net drug costs, or does it primarily redistribute savings within the supply chain without changing the total dollar amount flowing out of a health plan or employer's budget?
Yeah, it's a great question. And really the heart of we look at all the regulatory pressure and scrutiny, and that's, both at the state level and federal level. Obviously, the Consolidated Appropriations Act a few months ago puts a lot of focus on vertical integration and transparency and delinking, PBM revenue and things like that. We've seen FTC settlements, and we're going to continue to see more. I think what's important to start with is to say transparency does not equal cost reductions. That's fundamentally, transparency means I have more visibility to what's there. It will cause a change in the model, right? To say like, I will no longer charge things as a percentage of the drug's list price. I will no longer retain rebates, even though most rebates weren't retained today. Benefits will be based on sort of the cost and fair market value plus some acceptable margin and things like that. Sure, that will happen. Does it reduce costs? Not necessarily. And I think, history has shown parts of healthcare have gone through these types of structural changes before and come out preserving their profit margin, right? 20, 30 years ago, providers and distributors had to adjust from AWP-based reimbursement to ASP-based reimbursement, and they're just fine. And, Fortune 50 companies today, PBMs and health plans have had to adjust their model for, various changes in reimbursement, for various changes in benefit designs, for the types of activities they can engage in as PBMs or pharmacies and things like that. So, I think it's a safe bet to say they will absolutely shift the model and provide more transparency. Will they make less money, cost less money, and offer less value? No, I think those things may still very much, come out the same. There's a view to say it's a zero-sum game, sort of like I'm making money through the current/old model today. I shift that to a newer, transparent model. It's still going to cost the same, or I guess 9% more next year, no matter what we do. That's sort of what history has shown in terms of how things have evolved.